What do you see yourself doing after residency?
I'm seeing myself opening my own practice, and why I believe this is a path for me, because I enjoy working with a team of people with whom I see myself growing the fastest. And I enjoy being independent practitioner.
Okay. And just for everybody that's listening here, what specialty are you going to?
IR.
Okay. And so one thing that I would urge you to think of here is almost nobody, and I say almost because there are, of course, people that do this. Very, very, very few people go straight into their own practice immediately after residency. You will do it at some point in your career, but generally, like say you do 5 years of training, 6 years, whichever program you go to, that when you're done, number one, you're going to be nervous going into your first year as an attending. Number two, obviously it requires an immense amount of capital to start up your own practice. And so I don't generally recommend students to go that direction, because I think it's very, very difficult to, unless you say like maybe 10 years down the road or 5 years down the road after graduation, then that's totally fine. Like you could say, well, I hope to go into private practice, build up my skill set, learn how to navigate the wonders of being an IR physician. And maybe 5 years after that, I would like to encompass my entrepreneurial spirit and open up my own practice to be able to treat patients in my own way or something like that. That's totally fine. But I would say that your answer for this, you did 3 things really good and 1 thing that I would say to improve upon. So you can break it down like private practice or university style practice or academic, they say. And you can touch on a short-term goal and a longer-term goal. So I'll say break your passion up into a short-term goal after residency. So 0 to 5 years after graduation, and then a long-term goal after residency. 5 to 10 plus years after graduation. You touched on being team-oriented, which I think is amazing. And you touched upon you wanted to grow, which is amazing, because those are both qualities and characteristics that we're looking for applicants, right? Like you want somebody that can work with a team. You want somebody that is looking to grow. And you talked about wanting to become more independent, wanting to practice, wanting to give good care for your patients. And that's what it's all about. So I think that was very solid. Just a couple of things to keep in mind. And again, these are just my own personal perspective. It doesn't mean that what I'm telling you is the only way to do it by any means. So very solid. All right. Let's see. We got time for one more. Anybody else want to fire off a question?
Can I ask the one thing that I feel like I haven't seen a whole lot of or would like a little more insight about is like how you would recommend going about the behavioral, like tell me about a time and how you XYZ and how you responded to it, or here's a clinical scenario, like what would you do in this? I kind of was hoping to kind of get your insight on how you would recommend answering one of those, and we can use an example and do that, whatever is easier, but that would be something if we have time for that, I would really appreciate.
Okay. What day did you say that your next interview is?
It's on the 7th.
Okay, so we have a live session on the 31st, which I'm going to also do more live interview prep. And I was planning on diving into that, the ethical scenarios on that. Let me just touch on this briefly then, even though we have kind of like a little section for it next week that I wanted to touch on. Always, the key here is to always do the right thing for your patient. So it doesn't matter if it steps on toes. It doesn't matter if it ruffles feathers. At the end of the day, they want to make sure that you can make the difficult decisions. Okay? So make the difficult decisions. And a story that I commonly reflect on is I was a PGY 5 at the time, and I had a patient, and I literally still remember her name just because of how much that this story imprinted on me. I had a patient that when I went in to do rounds, it was a Tuesday morning because we had conference that day. And every Tuesday in residency, you know how it is. There's a conference at 6:30 in the morning. And so you have to round at 5:30 in the morning. And at 5:30 in the morning, I'm rounding on my patient, and she's covered belly button to the mid of her back with poop. And I totally understand accidents happen. Maybe she didn't even realize it. Who knows? But so I went to the nurse. The patient's nurse was nowhere to be found. So I went to the charge nurse who I was good friends with. And I said, hey, listen, like this patient of mine, she's got dried poop on her. So I know it's been there for at least a good 1 to 3 hours. And she was appalled. She's like, that's absolutely unacceptable. This patient, I think she was like 54. You know, she obviously had some other issues and developmental delays and stuff, but she wasn't like inherently incontinent. She just probably had nobody to help her to get to the bathroom, and she was a vasculopath, so she couldn't easily walk there herself. And she was still recovering from surgery. And so I said that to her. I was like, honestly, like, I get it. Accidents happen. Let's see if we can get this solved ASAP, please. And so she was like, no worries. I'm going to take care of this. Absolutely. I come back and I'm rounding at afternoon rounds, maybe 1:30 or 2:30 in the afternoon. And the patient was in the same dried, crusted poop that she had been in at 5:30 in the morning. So she has now went through 2 shifts with having this on her. So the night shift, as well as the entire morning/day shift. So at that point, I was left with no other option. I obviously went and brought it to the now the day team's charge nurse, discussed it with her. I had to submit an actual formal complaint about this inside of the reporting system, because at this point, it's now become neglect. The patient didn't just have a mistake or an issue. The patient was neglected to fix the issue. And so that obviously ruffled a ton of feathers amongst the nurses. And I'm quite glad I was a PGY 5 at that point so that I didn't have to deal with those ruffled feathers for super long. But at the end of the day, you have to do what's right for your patient and never back down. If you think something is wrong, or you think something is careless or neglect or anything like that, then absolutely you want to go that extra mile, and don't be afraid to touch on experiences like that in an interview, because they're not looking to see like, oh, is this person gonna rat me out, or is this person gonna like tell on me? That's not it at all. They just want to see, can you stand up for what you believe in, and what do you believe in? And so following the chain of command is important, like taking it to the person who would be immediately responsible for that action, or the person that's their superior. And if that fails, then taking it to the next level. In this example, like, I don't ever have to do an interview again, really, but it's like, this is something I could use at an interview in the future. And I'm sure maybe back in med school, I had other different examples that it's just now years ago that I can't remember. So at the end of the day, you just got to do what's right. They will not give you a hard time for whatever example you use, as long as you can give the story, share it with the person, and say, hey, I attempted to fix this problem, and this is how I took these steps. And that's it. That's all you can do. So don't shy away from it. Don't say I've never seen anything if you have. If you genuinely can't think of an example, then just ask for a second. Be like, hey, can I think about this for a second? That's a great question. And so that does 2 things. Is it buys you time, because it says, hey, I'm trying to figure out an answer, but let me think about it. And it also compliments your interviewer, which is disarming. And so you say, hey, that's a great question. You're literally complimenting your interviewer. And so subconsciously, people enjoy being complimented, and so they like that. So never be afraid to ask for more time to answer something, but always couple it with that small compliment like that. And then I think Julia had another question. I just saw something in the chat. What you got for me?
So when they have the question about most memorable interaction with a patient, or most meaningful interaction with a patient, is there any advices of how to like pick up the best one and what to avoid? Because I actually do have something in mind, but I don't know if that's going to be something I should really select as an answer.
So if they're saying what is the most meaningful or the most impactful experience, this is slightly different from the last one where it was a more ethical scenario that they're asking about. And so I would try to avoid negative interactions. And so this goes along the same lines of keep a good, positive vibe for your interview. Because think about it this way, sometimes, and like genuinely, and basically anybody in a procedural specialty will understand this, the stuff that sticks with you the most is not the home run that you had, it's the patient that didn't do well. I mean, almost universally. And like I've had 2 cases so far as an attending that were absolutely brutal. One, I was in the OR on a emergent take back for a thrombosed bypass for like 12 or 13 hours. Absolutely sucked. I'm never going to forget it. It was my first open case as an attending. My second open case as an attending, the patient passed away. Super disappointing. I mean, we told the family going into it, she had a 99% chance of dying. We were just going to take heroic measures because they really wanted us to. And they basically begged us to take her to the OR, even though I genuinely thought that probably going palliative or hospice was a better option. But she was like 60 years old and her whole family was there, super young, and they wanted her to go. And so we're like, you know what, we're going to do this just for the family. We're going to give it our best shot. We knew she wasn't going to make it. But those 2 cases, they obviously are going to stick with me forever. And so if you do have to touch on a negative case for this type of a question, if it's something you can speak passionately about, then you can. But you don't want to come across through your interview as focusing on negativity. So try to keep a good positive vibe if you can. But if it's something that genuinely was a negative outcome for a patient, that is fine to say. It really is. But just don't become like a negative person throughout the interview because of that question. And so I'm going to just put this little caveat here. If a negative patient outcome truly was the most impactful experience you've had, it's totally fine to discuss it, but keep your interview moving positively after that. Okay, so a good phrase that you can use to lead into this is truly, it's not only the good outcomes that you remember, it's oftentimes the patients that don't have the outcome we desire that really stick with you, or something like that. You know, this is just me spitballing an idea off the top of my head, but and it's true. It's like every single physician that's ever become a physician for more than 10 minutes knows that you remember the crap that went wrong. And so it's very fair game. You obviously, if you can think of a positive thing that really left a good impact, like maybe it's the first time you ever scrubbed in and it really changed your life because you're like, I want to do a procedural specialty, then awesome. That's a great one to include. But if it's maybe a patient that passed away on the table for you, or a patient that didn't have the right outcome that you had desired, then you can touch on it, but definitely keep these things in mind.